its origins. So let's begin with exogenous pigmentation. This results from external substances getting embedded into the oral mucosa, like metals from dental materials or pigments from medications and cultural practices. Unlike the endogenous lesions, these do not involve the melanin or melanocytes. Let's start with the most common pigmented lesion in the oral cavity, the amalgam tattoo. It is of iatrogenic origin, meaning it results from dental treatment itself. This typically happens when amalgam particles are accidentally embedded into the soft tissues during procedures like large restorations, endodontic treatments such as silver points or retrograde fillings, or even during tooth extractions. Facial pigmentation from amalgam has also been reported in dentists with occupational exposure. Clinically, amalgam tattoos are seen in about 1 to 3% of the population. They appear as small, flat and painless macules with a bluish grey to black coloration. You will commonly find them on the gingiva, alveolar mucosa, buccal mucosa, or even the floor of the mouth, often near teeth that were previously restored or treated. Histologically, we see fine brown or black granules embedded in the collagen fibers, usually around blood vessels or nerves. There is typically little to no inflammation, but in some cases, a mild lymphocytic infiltrate or even a foreign body type granulomatous reaction might be present. As for the management, most cases do not require treatment. They can sometimes be seen as radio-opaque spots on dental x-rays. However, if the pigmentation isn't radiographically visible, appears suddenly, or isn't near a restored tooth, a biopsy is advised to rule out other causes. Surgical removal is also an option if the lesion is in a visible area and the patient is concerned about aesthetics. Next is graphite tattoos. Graphite tattoos are a less common but interesting example of the exogenous pigmentation. They are caused by the traumatic implantation of graphite particles, usually from pencil injuries, and most often occur in childhood. Because of their unusual source, they are sometimes overlooked or misidentified. Clinically, they present as a solitary gray or black macule, most commonly found on the palate or gingiva. They can look quite similar to the amalgam tattoos, which makes the diagnosis a bit tricky, especially when there is no clear dental history to support an amalgam source. Under the microscope, graphite particles closely resemble those of amalgam tattoos. There is usually no distinctive histological difference that sets them apart visually. In terms of management, a biopsy is often recommended, particularly because the patient may not recall the injury or the lesion's history might be unclear. If the tattoo is in a highly visible or cosmetic area, surgical removal can be considered. In some cases, an autogenous connective tissue graft may be used afterward to improve the aesthetic outcomes. Next is ornamental tattoos. So, ornamental tattoos in the oral cavity are rare. These result from the application of pigments either for aesthetic reasons or as part of cultural or tribal traditions. The inks used are often amateur in nature and may contain carbon particles from burnt materials like wood, plastic, or paper. India ink, plant ink, and plant-derived pigments are also commonly used. In some cultural settings, especially within tribal communities, these tattoos can symbolize rites of passage. A unique example is a South African custom where individuals brush their gums with the chewed root of Euclea natalensis. This practice is believed to promote the oral health, and the plant's naphthoquinones are known to have antibacterial properties. Clinically, you might see actual lettering or intricate artwork tattooed onto the oral mucosa. Bright orange pigmentation, particularly from the Euclea natalensis, is also characteristic. These pigmentations are typically more common in women from certain tribes, and in most cases, they are transient and reversible. Management depends on the patient's wishes. If the removal is desired, Q-switch laser therapy has shown good results. For pigmentation caused by nuclear metastasis, no treatment is usually required as the discoloration fades naturally over time. So next is medicinal metal-induced pigmentation. This type of pigmentation arises from exposure to metals used in both systemic therapy and topical applications. It is less commonly seen but important to recognize, especially in patients with a history of chronic medication use or alternative treatments. Systemic therapies may include gold therapy, often prescribed for rheumatoid arthritis, and colloidal silver, which is used in some complementary medicine practices. This can lead to generalized discoloration. Silver, it can cause a condition called algeria, resulting in a blue-gray hue that may also affect the oral tissues, but it is rare. Gold, on the other hand, causes chrysiasis, which presents as blue-gray or purplish skin discoloration, but rarely affect the oral cavity. Gold therapy may also induce oral lichenoid reactions. Topical metal-containing agents are also another source. Silver nitrate, for instance, is sometimes used for recurrent ulcers, while zinc oxide is found in sunblock and ointments. Both can cause localized mucocutaneous pigmentation, especially in areas of damage or chapped tissues like the lips. Another common example is bismuth subsalicylate found in antacids. When it reacts with the sulfur compounds in the oral cavity, it can form bismuth sulfide, resulting in a generalized black tongue. This should not be confused with the black hairy tongue, which involves elongation of the filiform papillae. Histologically, silver and zinc show brown or black particulate deposits in the connective tissue, very similar to what we see in amalgam tattoos. These particles can be confirmed using the scanning electron microscopy and radiographic microanalysis. In bismuth pigmentation, pigment accumulates on the tongue surface, but there is no change in the deeper tissue. As for management, pigmentation from systemic exposure, like silver or gold, is usually permanent. Discontinuation of the causative agent, such as bismuth, is the first step. In the case of black tongue, mechanical cleaning like tongue brushing can help reverse the appearance. But due to the similarity in appearance to other pigmented lesions, clinical pathologic correlation is essential for a correct diagnosis. Next is heavy metal pigmentation. It results from the ingestion or exposure to toxic metals such as lead, mercury, bismuth, and arsenic. These metals can enter the body through various sources, commonly from occupational settings like industrial plants or environmental through old paint, outdated plumbing, and contaminated seafood. The pigmentation itself occurs when metal salts leak out from the blood vessel in areas of chronic inflammation. This leads to deposition of pigment within the oral tissues. Clinically, the most recognizable sign is a diffuse pigmentation of the oral mucosa. One classic feature is a grey to black metallic line along the free marginal gingiva, often called lead line when associated with lead poisoning. In some cases, you might also observe generalized mucocutaneous melanosis that gives a more widespread discoloration across oral or even facial tissues. Importantly, oral pigmentation might be the earliest visible sign of heavy metal toxicity, making it a potentially life-saving clue. Systemic signs often accompany it and may include behavioral changes, neurologic disorders, intestinal pain, and excessive salivation or sialuria. So when we see this type of pigmentation, especially in combination with systemic symptoms, it is essential to consider heavy metal toxicity in the differential diagnosis and refer for appropriate medical evaluation and detoxification. Next is hairy tongue. It is a benign condition that primarily affects the dorsal surface of the tongue, especially the middle and posterior third. While the exact cause remains unknown, several contributing factors have been identified. These include chronic antibiotic use, smoking, both tobacco and crack cocaine, psychotropic medications, and other drugs like tetracycline, linezolid, olanzapine, bismuth, and erlotinib. Certain foods, drinks, and even confectionaries have also been associated with this condition. Clinically, hairy tongue is characterized by the elongation of the filiform papillae, giving the surface of the tongue a hair-like appearance. This can range in color depending on the presence of chromogenic bacteria. It can be white, green, brown, or even black. Although it can look alarming, it's usually asymptomatic and rare in children. A well-known subtype is the black hairy tongue, which is often caused by bacterial pigmentation combined with poor oral hygiene. Microscopically, we see hyperkeratosis and elongation of the filiform papillae with superficial microbial colonization. There is no deeper tissue involvement, which confirms its non-invasive and harmless nature. So the management is straightforward. The first step is mechanical cleaning, either brushing the tongue with a toothbrush or using a tongue scraper. Patients should also avoid food and drink that are known to cause staining, since the condition's cause can be multifactorial. Recurrence is possible, especially if the underlying contributing habits persist. So now let's take a look at endogenous oral pigmentation. That means the pigmentation that comes from within the body rather than from external substances. So there are four major sources of endogenous pigmentation, which are vascular, hemosiderin, melanin, and bilirubin. Starting with vascular pigmentation, this results from abnormal blood vessel in the tissue. It can be developmental, genetic, or related to autoimmune condition. Example including hemangioma, Kaposi sarcoma, and angiosarcoma. These usually appear reddish to bluish depending on the blood flow in the lesion. Next is hemosiderin, which is related to the breakdown of blood. This often appears after trauma or inflammation, and it's also seen in genetic bleeding disorders. You will see lesions like ecchymosis, purpura, and petechiae, which are all forms of bleeding under the mucosa. Then we have melanin. It is influenced by hormones, genetics, and even certain medication. Conditions like melanocytic nevus, lichen planus pigmentation, Cushing syndrome falls under this category. And finally, bilirubin. This comes into play when there is liver dysfunction or trauma that leads to elevated bilirubin levels in the blood. This results in a yellowish discoloration, commonly known as jaundice. So now that we have covered the broader categories of the endogenous pigmentation, we are going to narrow our focus to a specific subset under the melanin category, which is the focal melanocytic pigmentation. These are localized pigmented lesions caused by melanin-producing cells known as melanocytes. So the first one is freckles or aphelis. It is a common form of focal melanocytic pigmentation, and they are generally considered to be developmental in origin. Their appearance, particularly in childhood, is linked to genetic factors, especially polymorphisms in the MC1R gene, which plays a role in melanin production. Another susceptibility gene has also been identified on chromosome 4q32 to q34. Clinically, Freckles are small, around 1 to 3 millimeters in size, well circumscribed, and range in color from tan to brown. They are completely asymptomatic and most commonly seen in light-skinned individuals, especially those with red or blonde hair. A key characteristic of freckles is their response to sun exposure. They tend to darken with prolonged sunlight, but will gradually fade with age. This change in pigmentation isn't due to an increase in the number of melanocytes, but an increase in the melanin production. Next, we have the oral labial melanotic macule, which is the most common pigmented oral lesion of melanocytic origin. This lesion is benign, and unlike freckles, it has no skin equivalent. The exact cause isn't fully understood, but local trauma or irritation may contribute to its development. Unlike freckles, however, this lesion is not related to sun exposure. Clinically, it is more commonly seen in females and usually present in adults. The most frequent site is the lower lid, also referred to as labial melanotic macule, though it can also appear on the gingiva or elsewhere in the oral mucosa. These lesions are less than 1 centimeter, well defined, and can be oval or irregular in shape. The pigmentation is uniform, usually brown, and the lesion is completely asymptomatic. Histologically, you will find increased melanin in the basal cell layer, but no increase in the number of melanocytes, which help distinguish it from melanocytic neoplasms. The pigment tends to be more concentrated at the tips of the retipex, and in some cases, melanin may leak into the underlying connective tissue or lamina propria. Now I will hand it over to Danish to continue.
Hello, good morning. So I will continue for focal melanocytic pigmentation. So first is oral melanocytoma. It's unusual, benign melanocytic lesions that unique to mucosal tissue, and it's an innocuous. It means it's not harmful. It's not non-harmful lesions, and is spontaneously resolved with or without surgical intervention. Most patients report a rapid onset and acute trauma or a history of chronic irritation usually precedes the development of the lesions. The underlying source of the irritation should be eliminated to minimize the recurrence. For the clinical feature, it is a rapidly enlarged, ill-defined, darkly pigmented macular or plaque-like lesion, and it's a black female predilection. It most occur in third to fourth decade of life, designed as solitary lesions, but bilateral and multifocal lesions have been reported also. It is asymptomatic, not pain, and the size ranging from small and localized to large diffuse area of involvement, and the borders are typically irregular in appearance. For the pathology, is characterized by proliferation of benign dendritic melanocytes throughout the full thickness of acanthopic and spongiotic epithelium. You can see a pigmented macule on the attached and marginal gingiva displaying irregular border. For the diagnosis, biopsy is necessary. It is important because it's to obtain the definitive diagnosis because oral melanocytoma may resemble other melanocytic lesions, for example, pigmented nevus, melanotic macule, and melanoma. Next is melanocytic nevus. It arises as a consequence of melanocytic growth and proliferations. For intramuscular nevus, is most frequently observed, followed by common blue nevus, and compound nevus are less common. Junctional nevus and combined nevus infrequently identified, and the most nevus cells tends to be round, ovoid, or spindle shaped. Generally, genetic and environmental factors are thought to play a role in nevogenesis. Effect of sun exposure on cutaneous nevi development is well recognized. For the clinical feature, it is rare where it typically presents as solitary lesions and more common in females. Lesions are usually asymptomatic, small lesion which is less than 1 centimeter, solitary brown or blue, well circumscribed nodules or macule. And it may develop at any age, but most cases are identified in patients over the age of 30 and common site is hard palate. So for the pathology, nervous cells initially maintain their localization to basal layer, reside at junctional epithelium and basement membrane and underlying connective tissue. So nervous cells have three types: junctional, compound, and intramucosal. Junctional nervi usually small, less than 5 mm, macular or non-palpable, and tan to brown in appearance. The compound nervi cells are variably pigmented. For intramucosal nervi, superficial melanocytes are heavily pigmented. Melanin is less evident in remaining cells. For diagnosis, biopsy is necessary for diagnostic confirmation because different diagnosis will have different treatment. So, for example, treatment of such is complete but conservative surgical incision, or we can use a laser and intense pulse light therapies also used successfully for cutaneous nerve treatment. You can see here in microscopically, number 1 is normal, 2 is junctional, and compound is the combine of junctional and intramucosal, and the fourth one is only below only the intramucosal. So this is more important. So for the malignant melanoma is less common but most deadly of all primary skin cancer. The risk factor is multiple episodes of sun exposure, immunosuppression, and presence of multiple cutaneous nervi family history of melanoma. The gene mutations is first one is tumor suppressor, CDK4, CDKNA2, and P16 or proto-oncogenes, BRF, HRAS, and RAS. For the clinical feature is predilection in male, age is over 45 years old, common site is molar region or facial. We need to know that the criteria of the malignant melanoma, which is asymmetry, irregular border, color, diameter, and surface of elevation. This is an example of melanoma. First one, mucosal and oral melanoma. You can see the picture there. Malignant melanoma exhibit the macular involvement of the anterior hard palate, and its majority developed in head and neck region. Common site is sinonasal tracts and oral cavity, and predilection in black skin and Japanese males. Next is oral melanoma. The example picture is malignant melanoma presenting as a mass on the maxillary gingiva and present over age 50. The common site is palate and followed by maxillary gingiva, and no distinctive appearance can be macular, plaque-like or mass forming, well circumscribed, exhibit focal or diffuse area with brown, blue or black pigmentation, and it can be symptomatic or asymptomatic. So this is roughly our discussion about focal and their treatment. So next we go through for the multifocal or diffuse pigmentations. The first one is physiologic pigmentation. The clinical feature is this is most common multifocal diffuse pigmentations. Is common in dark Caucasian individual, for example, blacks, Asians, and Latinos. The common site is gingival, start detected on a child, not de novo adults. For histopathology, increased melanin pigmentation, brown to black discoloration, and for differential diagnosis of this lesion is drug-induced, smoking-induced melanosis, and hyperpigmentation associated with endocrinopathy and other systemic disease. This is the example picture of the physiologic pigmentation, and for the treatment, we can do a gingivectomy, cryosurgery, or laser therapy. Note that pigmentation may eventually recur. Causes of repigmentation remains unclear. Next is drug-induced melanosis. For the cause of disease, of course, is from the drugs, deposit of drug metabolites. For example, drug is anti-malaria, for example, chloroquine, hydrochloroquine, and quinacrine. And next is phenothiazine, chloropromazine, oral contraceptive, and cytotoxic medication, for example, cyclophosphamide and busulfan. For the histopathology, bacillar hyperpigmentation can be seen, melanin incontinence without a concomitant increase in number of melanocytes. Drug metabolites stimulate the melanogenesis, and some drugs show physically bind to melanin. Here are the example of the drug that I take from Burkitt's book. This is a picture of the drug induced melanosis. It has been estimated that 10 to 20% of all cases of acquired melanocytic pigmentation may be drug induced, and it can be diffuse, localized, multifocal with multiple surface. And the common site is hard palate, any flat and no nodulatory swelling. Sun exposure may exacerbate cutaneous drug induced pigmentation. For the diagnosis, pigmentation associated with hormone therapy may tend to persist for longer periods of time despite discontinuation of the medications. Laboratory test is may necessary to rule out an underlying endocrinopathy. Next is smoker melanosis. It is unknown but possible when one or more chemical compounds incorporated within cigarettes rather than tobacco may be a causative agent for this lesion. Heat of smoke is a main cause of this lesion. For the histopathology, bacillar melanosis and melanin incontinence is present and non-pre-neoplastic conditions. For the clinical features, site including anterior vestibular maxillary, mandibular gingiva, buccal mucosa, lateral tongue, palate, and floor of the mouth. It's a brown, flat, regular, map-like configurations. This example picture. Next is post-inflammatory of hyperpigmentation. For histopathology, is bacillar hyperpigmentation and melanin incontinence. For the clinical feature, is common in dark complexional individual, focal or diffuse in area of previous injury or inflammation, and some cases also pigmentation on post-surgical healing of palatal donor cells for free gingival graft. And the last one is melasma, or we can call it cloasma. For the mechanism of this lesion is due to sun exposure and hormonal factor, pregnancy and contraceptive hormone. For the hormone is estrogen and combined with progesterone can induce this lesion. And also thyroid abnormality, for example, is hyperthyroidism. For the histopathology, bacillar melanosis with no increased number of melanin but increase in size. For the cause of the disease is sun exposed area of skin, especially skin. It affects 5 million in US, and the common site is forehead, cheeks, upper lips, and chin. Most commonly in female and dark skin prediction. This is an example picture of the melasma. For the treatment is resolved after perturbation, cessation of exogenous hormones, regulation of endogenous sex hormones level, and topical administration of 3+1 products. The product is 4% hydroquinone, 0.05% tretinoin, 0.01% fluocinolone acetonide, and SPF 30 sunscreen. SPF stands for sun protective factor, and 30 means it's only allow about 1/30 of the UV ray to reach your skin. It's good for daily use. This is roughly our multifocal and their treatment. So this is our reference. That's all from me, Doctor.
Okay, thank you for presentation, Mia and Danish. It was very comprehensive one. So I think we have a part 2 of the presentation also, which is coming up next week or week after. So, do you have any doubts? Your friends can ask doubts. Any questions? Please write it in the chat box. Okay. So, from this topic, I think malignant melanoma and differential diagnosis between different intraoral pigmented lesions like melanoacanthoma, oral melanocytic macule, and amalgam tattoo are important. Okay. Now, I just want to remind you that we've taken away this topic from the upcoming exam because we are not able to finish it on time. So, only part one has been covered. Upcoming OSCE, this topic is not included. I just wanted to tell you that. And yeah, so kindly send me the PDFs before the presentation so that it can be uploaded on time. Okay, for this one is okay. You can email it to me or you can send it to me right away. All right. So if there are any doubts, you may ask now. Okay, even if you're very shy, never mind, you can type it in the chat box, or if you don't want to ask, I think you need to read up the topic and then you might get some more doubts. Okay, there are no
Doctor,
Yes, please.
just now you mentioned that malignant melanoma is important and then differential diagnosis of? Can you repeat that?
Oral melanoacanthoma, you can write it in the chat box. The three intraoral, at least 3 or 4 intraoral pigmentations initially mentioned by Mia. Okay, one is an amalgam tattoo because they all look very similar. Okay, oral melanocytic nevus. But it doesn't mean that you read only these. You need to be able to differentiate it from the others. Okay. All right. So Danish or who spoke about melanoacanthoma? I think it was Danish. Maybe you need to look at the spelling that you've written in your notes. Yeah. Again, to confirm it. Yeah. All right. So pigmentation on the skin is different from pigmentation on oral mucosa, which is different from pigmentation on gingiva. Okay, so gingival pigmentation, very clearly they have given you examples of drug-induced, physiologic, and anything else. Yeah, sometimes even graphite tattoo can also be there on the gingiva. Okay, so most commonest pigment is melanin. So that's why everything appears brown. Okay, you don't get very different colors like green or I can't imagine any other color. But when it is a blood involved pigmentation, it will definitely change color because bilirubin changes to biliverdin. So it starts off as reddish, then becomes bluish, and then yellow, and then slightly greenish before it fades away. Okay. So there's a little bit of an overlap between bleeding disorders and pigmentation, which is caused by bleeding into the mucosa. So that's why ecchymosis and petechiae look like pigments, but they're actually, bleeding conditions, right? So that differentiation, I think, an overlap, you should be able to differentiate. Are you following me?
Yes, doctor.
Okay, good. Right. So yes, read the chapter. Their notes are really good. So go through the notes. Maybe you can just flip through the pages of the textbook as well. Right. So please send me the notes so that I can upload it on the e-portal. Make those slight corrections and send it to me, Danish or Mia, one of you. Okay, then that's all for today's seminar. We will see you in the next class, which is a continuation of orofacial pain. Okay.